Molt bona tarda a tothom. Disculpeu, però estàvem mirant si ja teníem problemes de so. Doncs, benvinguts a aquesta nova sessió tècnica. Avui la farem en anglès i en castellà i la sessió és Can people afford to pay for healthcare? Inequity in financial protection in European health systems. ¿Pueden las personas pagar la atención médica? Desigualdades en la protección financiera en los sistemas sanitarios europeos. Hoy abordaremos, pues, las implicaciones para las políticas sanitarias de las desigualdades económicas en el acceso de los sistemas de salud europeos. Nos acompaña e iniciará esta mesa redonda Tamas Zebetovic, el Tamas bien conocido y al cual le agradecemos que nos acompañe hoy. Es de la WHO Europe Barcelona Office y nos proporcionará una visión general de los últimos hallazgos sobre la accesibilidad económica de la atención en salud en Europa. Seguidamente, Enrique Bernal Delgado nos hablará sobre
el estado de la cuestión aquí en España.
Exacto, del estado de la cuestión aquí en España. Y Sarah Thompson, también de la WHO Europe Barcelona Office, analizará la resiliencia de las políticas de financiación en salud, así como el resultado de las respuestas de los sistemas de salud a las crisis mundiales, financiera y de COVID y a los aprendizajes para el futuro. Rápidamente presentaré a los tres ponentes de esta mesa, que podemos decir que es una mesa de máximo nivel. Tamas Zebetovic, el doctor Tamas Zebetovic, él es el jefe de la Oficina de Financiamiento de Sistemas de Salud de la OMS en Europa, y en Barcelona, perdón, y dirige la asistencia técnica de la OMS a los Estados miembros sobre financiación de la salud en la región europea. Una parte clave de su trabajo es monitorear la protección financiera en los sistemas de salud europeos y además mejorar las políticas de cobertura para reducir las dificultades financieras y las necesidades insatisfechas. Tiene una amplia experiencia en capacitación y consultoría en políticas de financiamiento de la salud y desarrollo de capacidades en países de Europa Central y del Este. Es médico de formación y tiene 2 maestrías en políticas y gestión de la salud de la Universidad Semmelweis de Budapest y la Universidad de Londres. Enrique Bernal Delgado, él es médico y máster en salud pública y máster en economía de la salud. Tras un periodo como visiting scholar on the Dartmouth Institute Medical School en Estados Unidos, fundó el grupo de investigación Data Science for Health Services and Policy en el Instituto de Ciencias de la Salud de Aragón, donde actualmente ocupa el cargo de científico senior. Su investigación se desarrolla en el estudio de variaciones injustificadas en el desempeño de los sistemas de salud, en la efectividad comparativa de intervenciones complejas entregadas a poblaciones crónicas y frágiles y en el desarrollo de metodología para la reutilización de datos masivos del mundo real. Y finalmente, Sarah Thompson, nuestra querida Sarah Thompson, ella es especialista senior en financiación de la salud en la Oficina de Financiación de Sistemas de Salud de la OMS en Barcelona, donde dirige un proyecto que analiza si las personas en Europa pueden pagar la atención médica. También ha dirigido estudios sobre la historia, la política y el desempeño de los seguros de salud privados a nivel mundial y el impacto de la crisis financiera mundial del 2008 en los sistemas de salud en Europa. Antes de trasladarse a Barcelona desde el 2013, ¿no? Hace 9 años que estás aquí con nosotros, Sara. Sara fue profesora asociada de política sanitaria en la London School of Economics and Political Science y del 2013 al 2016 miembro del panel de expertos de la Comisión Europea sobre formas eficaces de invertir en salud. Con lo cual, gracias a nuestros 3 ponentes, le damos la palabra a Tamas.
Thank you very much. Is it on? Can you check whether it works? Thank you. Thanks for this introduction. Sorry, I will deliver this in English, but it was very nice to hear the introduction for the first time in Castellano. I was carefully listening, but my Castellan is very, very limited. So please bear with me. Oh, can we go back to the first slide, please? And thank you. So I'm the head of the office of the Barcelona office for health system strengthening, and we are privileged to have an office in this magnificent site at Sant Pau Hospital, the historic site. So at this point, I always have to start by thanking Catalunya for hosting this WHO office here, which I hope is an office that is making history. And maybe this is quite a huge word to say, but thanks to Sarah and my colleagues in this office, I think for the first time in Europe, we have a systemic monitoring of financial protection across the European countries, which in WHO includes all former Soviet Union countries. So it's a region of 53 countries of Europe, not just the geographical Europe. And this has never been done in the past. There were some random studies by researchers looking at some countries, but never a systematic overview of the countries using a comparable methodology. This is not the first time that we are here, and thank you again, Maria Luisa, for the invitation. And we are always very pleased to come. And this time we have Enrique as well, one of the authors of the Spanish report on financial protection, which I know is a term that is not widely known. Therefore, we gave a much easier to understand title to the reports that we have. Can people afford to pay for healthcare? Which, you know, some people would argue, you know, yes, probably they can, otherwise they wouldn't use it. But we did not have the evidence to say, okay, how many people there are who cannot afford to pay for healthcare. And what we see is that there is huge inequalities, or rather, I should say inequities in across Europe and also within countries. So as many of you know, and sorry for those of you who are very familiar, but let me do a bit of an introduction to this work, which started several years ago. Monitoring financial protection is part of monitoring universal health coverage. It's one of the sustainable development goals. There are indicators which are part of the SDG indicators. Countries can decide whether they want to monitor this or not. We decided for them that we want to do this monitoring, and also we provide this service to member states. We developed a new method that is relevant for also for high-income countries, not just low-income countries, which is much more the case with the global SDG metrics. And this slide just shows you by now the impact is that the European Union is using the numbers that are produced here in Barcelona with experts in the office and across the European region, national experts working with us to produce analysis of the country-specific analysis, because we are not just producing numbers. Indicators on their own will not tell policymakers what to do, and that's what they are interested in. So the large part of the work is country-specific reports and not just a regional report. The first regional report we published in 2019, and the second regional report will be published this year at a major event in June here in Barcelona for the first time. The first report covered 24 countries. This second report will cover 42 countries, and many of them with quite recent updated numbers. The OECD is using our reports, and of course the European Observatory, not because the director is a Catalan, but because it's the research evidence that they always use. And of course, the global reports also cover the European numbers. So access to healthcare without financial protection is really in many countries the case. And I've just came back from the Western Balkans, from Bosnia and Herzegovina, where we had the first Bosnia Bosnia and Herzegovina study report launched. And it was again a reminder that we cannot just assume that excess alone is just having coverage, everybody being covered by insurance is sufficient, or an NHS or national system. So therefore, we need to look into the numbers and the functioning of these umbrellas, which this image is trying to convey. Financial hardship may be experienced by people who use healthcare. So those who don't use healthcare, they may not suffer from financial hardship. Therefore, when we look at financial protection, we have to look at both hardship and unmet need. And as you will see in the Spanish study as well, we have done so. And of course, financial protection is all about whether people have to pay out of pocket at the time of using services, not whether it's hard to pay the taxes or health insurance in advance. All health systems use out-of-pocket payments. So the question is, what level of out-of-pocket payment leads to financial hardship? And as you can see here, across the European region, 53 member states, Spain is somewhere in the middle, and WHO's recommendation is to keep out-of-pocket spending as a share of total spending below 15%. And Spain does not manage to reach that target. But Spain may still be doing well in terms of financial protection. So this is just to show that just by knowing how much a country spends out of pocket, that does not tell you whether there is good or bad financial protection. It's possible to have good financial protection even above 15%, but what we will see also that the evidence shows that there is a strong correlation. So actually the WHO recommendation should, I think, stay. So the two indicators which will help you to know whether there is financial hardship by some households are the catastrophic out-of-pocket payments, which we define as out-of-pocket expenditure that are more than 40% of households' capacity to pay. And that's where it's very important that we refer to capacity to pay, which means that it's not the total income or expenditure by the household, but we first deduct for the cost of meeting basic needs. And in this case, we count food, rent, housing, and utilities. That there is a hierarchy of meeting needs, and apparently, people first want to feed their children before seeking healthcare, just to give you one example. And the other indicator is the impoverishing out-of-pocket payments. Those payments that push households below the poverty line, or those households which were already under the poverty line, further below and further impoverished. So this is the update which we were requested to, and my job is to show you the update, the most recent data in this chart, I think 39 countries, but soon 42. And you can see that Spain is doing really well. So despite the relatively high level overall out-of-pocket expenditure as a share of total spending, Spain is one of the best performing countries in the European region. However, if you look at Spain, there is a lot of the red, and the red stands for those households which are further impoverished. The orange are those which cross the line. Before paying for health services, they were not poor. After paying for health services, they become poor, using this basic needs line, which we established to have a comparable system. This means that those very few households, but for them, they don't care that they are only few, they suffer. So for those households, this means that they are already poor. Most of those who are facing impoverishing expenditure are those who are already poor. And that's where protection may need to be further improved. On the catastrophic incidents, again, Spain is doing very well, among the best, and that is a higher level in terms of percentage, because it counts not only those who become poor, but also those who may be well off, but they spend 40% of their capacity to pay. So I think the three key questions that we are really going into in each individual country reports is that who are these people who are suffering and what drives financial hardship and why we see these incidence levels in the different countries. And oops, not everyone can afford to pay for healthcare is something that we refer to as out-of-pocket spending. So oops is the acronym for that, and it has a nice connotation also in the English language. So the first question, who? This chart shows, again, the catastrophic incidence, that's the lighter brown, but the darker brown shows the incidence in the poorest quintile, the poorest 20% of the population. And as you can see, in the poorest quintile, the incidence is much higher, of course, than in the overall population. So that message from this chart across the European region is that it's mainly poor people who suffer. Of course, this sounds intuitive, but it's not necessarily the case. It depends also on how you measure financial hardship. To the what question, what drives financial hardship? This chart shows the service composition that is behind those numbers that you could see here in the previous slide. So for those low incidence countries, we zoom into those small bars and look at what are the main drivers of financial hardship. And in Europe, what we see is that the three main drivers are medicines, the red, medical products, the orange, and dental care, the blue. This chart shows the composition for the poorest quintile only. The total population, for the total population, it would be very, very colorful. But the reason why we look into this is because we already know from the previous chart that it's mainly the poor who suffer from financial hardship. Interestingly, in Spain, but you will hear more from Enrique on that, medical products are the leading driver of financial hardship, while in rest of, or the majority of the European countries, it's medicines. Why is the question. On medicines, and let me just focus very quickly on the European region in general, what we see is that in many countries, only a small part or share of the cost of medicines are covered by public sources. So for example, in the eastern part of region, less than 50% of the total cost of medicines are covered by public funds, while in OECD and EU member states, it's of course much higher. In many cases, it's more than 75%. But on the other side, you see also part of the reason. All EU countries use co-payments for medicines, not necessarily for inpatient care or GP visits or specialist care, but for medicines, all EU countries use co-payments, and not just simply co-payments, but percentage co-payments. And what does percentage co-payment mean? It means that if you happen to have a sickness that has a higher priced medicine to treat, then the patient has to pay more than those patients who were clever enough to choose a low-cost sickness. And of course, I'm making this joke only because it's not the patient who chooses. So why are we asking the patient to pay a share of the price instead of a fixed low co-payment? And this is exactly what we found, that in those countries where financial protection is strong, they use three main, very well-established and well-functioning protection mechanisms for prescription medicines: low fixed co-payments, exemptions for poor people and multiple chronic conditions, disease people with multiple chronic conditions, and annual caps on co-pays, or a mixture of those, maybe not all of them, but these are the instruments that seem to work across Europe. And then let me just reflect a little bit again on Spain, because medical products and dental care are almost entirely financed through out-of-pocket spending in Spain, and well above the average, the EU 15 average. So what you see here is down there, the EU 15 average for dental care and medical products, up there for Spain, and that shows that that's where Spain is leaving it to the out-of-pocket expenditure part of financing medical products and dental care. And that's one of the reasons why we see the incidence in terms of incidence and also the composition of the drivers of financial hardship. Can you help me forward? For some reason, this doesn't work now. Good. And just one slide on unmet need, because unmet need has to be part of the analysis. And again, here I'm referring to dental care as one of the examples for unmet need, because dental care may be a source of financial hardship, and that's what we see across Europe, that it's a source of financial hardship for rich people, but for most of the poor people, it's unmet need. Now, interestingly, in Spain, it's also for poorer people. They do spend on dental care, but they still have quite large unmet need for dental care at the same time. And again, here, what we see is the inequity here. The poorest and the richest quintile have very different levels of unmet need. You can still enjoy the fact that you're doing much, much better than Greece or Portugal. But there are some countries which are doing better than you do. And again, the last question, and that's where I finish on why, or the last slide I have on the question of why. The main issue is, of course, the high level of out-of-pocket spending. On this chart, what you see is the correlation between the share of out-of-pocket expenditure in the countries as a share of total spending. You know, I argued that 15% is the benchmark that WHO recommends, and the incidence of catastrophic expenditure by households. There is a strong correlation, but there is a large variation as well. And the variation at the same level of out-of-pocket share is explained by the protective policies that any country employs. And that's where Spain seems to be doing very well. So despite having a high out-of-pocket expenditure, Spain has the protective policies in place. So that's what explains your relatively good results, despite the fact that you're spending more than 20% out of pocket overall. And that's what makes Lisa smile. Some of you may remember the video that we showed, and it's available online. The link is here. So once the slides will be shared, people can look at it. Lisa is an older woman who lives on a relatively small pension, has multiple chronic conditions, and had to face the difficult decision of whether to fill in her prescription or pay the electricity bill. And I'm bringing this back now because the cost of living crisis makes it even more important these days that we find these lists and exempt them from paying co-payments. So thank you very much, and I'll stop here because my job was just to give you a short overview and the updated numbers. Thank you. No, and that one as well. Oh, you want to stand up? Oh, you're standing.
So your job was giving a quick overview, but you've touched everything. So, so my work now is just putting some basis over your statements a bit and reflecting on the underlying causes of the relatively good protection of the system. So you've covered already something, but I can, may you have me? Yeah, what is, you posed on the logic of a study, next slide. Okay, it's mine. So in the end, the problem that we face in these studies, and you haven't mentioned that, is the same for all the member states in the WHO Europe community, which has a lot of advantages, not because of the numbers, but because of the mutual exchange of underlying causes behind it, which was interesting for me is trying to understand why this last slide that you showed is happening. Because this is not a black and white thing, it's a question of those response, and it's not clear. The point that we cover in the Spanish report is the same as in the others. So in the end, we are trying to figure out if people is actually suffering from some financial hardship because he or she has to pay for care upon their capacity, the ability of payment is of interest for any policy in the end, and is for the academy as well. So this is why we are interested in joining your collaborative. And in this particular case, we want to the underlying aim of this is trying to figure out what is the degree of financial protection of the Spanish households using a specific methodology, which is the same methodology and the others. And it might be a question of, I mean, many times contentious. Actually, we were discussing a lot about whether we should use income instead of actual expenditure. But anyway, it's expenditure where we are talking about. When we are defining the families by quintiles, we are talking about quintiles of expenditure, no quintiles of income, which is a bit tricky thing to take into account. But for comparison purposes, seems to be more reliable, the one on expenditure. Just for you to have at a glance a view of how in Spain this looked like in terms of the, this is the overall, the average expenditure in public expenditure on health, out-of-pocket expenditure on health, and voluntary health insurance expenditure on health. And more or less seems to, I mean, take into account the scale effect. So this is in the end are constant euros per capita, and you have, more or less at the end of the period of study 2018, 1,600 of public expenditure. It's quite constant. You can see there the impact of this, of the crisis, of the financial and economic crisis in 2008. Took time to recover, and we are not yet there. I mean, we are now, because of the public expenditure during the pandemic, we are far beyond that, far above that level. You also see there is an increase, a steady increase of out-of-pocket and a steady increase of voluntary health insurance, more than what you can perceive that in the graph because of a scale effect. But we can summarize this as, in terms of the overall expenditure in the system, in Spain, more or less, we do have 70% of public expenditure, 30% of private expenditure. 2020, because of the crisis effect, the money that was injected into the system, we are in 74-26% public-private. And within the private, the 75-80% is out of pocket, and the rest is private. Buying voluntary health insurance, maybe for complementary purposes or for supplementary purposes. But in total, and 7 to 10%, depending on the year, of the total expenditure is on voluntary health insurance. Just to give you some tips on what's the situation and why WHO looking for a threshold of 15% of our pocket is a bit, scared with Spain and saying, no, you can, I mean, how on earth? You have to move this down below the threshold of 15%. We don't go below 22% for many years, actually. But the point of these studies is not just looking at how the system is financed, as you have said, it's also how is the coverage policy, who is entitled to get the basket of benefits, how wide, how deep the basket of benefits is, and then how it's paid, and who is paying for that. So these are the three elements to take into account, and we have to combine it. So we are taking here a look to the financial part of it, but we cannot just detach this from the analysis of the other parts. We need to do this kind of analysis to actually understand why there may be a Spanish paradox. We can coin that term, maybe, the Spanish paradox, that paying a lot of pocket, we have our families highly protected. And this is the final actually element. Well, as the methods for this, just you mentioned already. Keep in mind, this is a study based on surveys, public surveys. This is household budgets surveys, are the social living conditions survey, and the European health survey. So everything is survey. So I'm not going to get into the limitation of this kind of approach, but in the end, it's consolidated, it's comparative, and you can get a lot out of that. It's not looking for causation, so it's obviously we are just looking at describing how things happen and looking for some correlations that may be of interest to further discuss on the underlying cost of this. There are measures of interest, as Thomas mentioned already. The impoverishment is one of them. When you pay out of pocket for your healthcare, this is average, household average. When you pay for your healthcare, where this family ends up being is above the line of poverty, so the basic needs are covered, food, housing, and utilities, and how far from this line the family is after paying for the care out of pocket. And then you have families at risk of impoverishment that actually, after paying, got below the 20% above the line of poverty. So there is a very thin range there, and the risk of impoverishment is clear if you keep paying for your health out of pocket, or if you are impoverished because so you are below the basic needs line, so the poverty line, because you paid out of pocket for your healthcare. In those that were above the line of poverty, so those are the impoverished, and the further impoverished are, irrespectively of they were at the beginning were below the line of poverty, they are still have to pay for that. And we'll see that in Spain, this, even though it's a small amount of families, not that small though, but a small amount of families relatively, are those that suffering the most in this case. And then there are two, I mean, I will use this as a stratifier in some of the, I've taken some elements. If you've seen already that the report is plenty of graphs, plenty of data. So I've just, take some that I think can be a good summary of what we've seen. And I use this expenditure as a stratifier of the catastrophic expenditure, rather than, going one by one on the effects on each. And so I will highlight two elements, one of our catastrophic expenditure on health and the other one about unmet needs on health. Some results. Taking again a closer look to Thomas' points is on this out-of-pocket goes to what? To what kind of service? And you can take out of the survey, household budget survey, these 6 different services or goods: drugs, pharmaceuticals, hospital assistance, diagnostic testing, outpatient care, medical products, and dental care. These 6. You see that we've got there from 2015 to 2016. This is a tricky point you have to take into account when reading the results. We highlight many times along the text. The first thing is that, and most important actually, dental care. You see dental care now, the blue one is dropping from 2016 on, is because there was a change in the methodology. So many things that were considered within the dental care part now are medical products. So this is where the orange one expanded. Medical products, for example, dentures, braces, the material, the dental material that they use. And part of the dental care is also on outpatient care. So this change in the methodology in 2016 makes a difference in the interpretation. So you can see, well, maybe dental care is not that important. No. If you take, you can actually, the expectation is the blue line, the blue column continues more or less the same height. Okay, you see the medicines, actually the co-payment plays a big role here. Hospital care is the thinnest one, but we'll see some differences across expenditure quintiles. And diagnostic tests are increasing a bit as the share of it, as well as outpatient care. If we see this by expenditure quintile, on the left-hand side, the poorest or the worst off, and on the right-hand side, the richest, the better off, then you have differences in the composition, in the share. You will see that, for example, hospital systems is very much a question of the fifth quintile, of the richest. Okay, while medical care, pharmaceutical care is more on the poorest side. For example, yes, picking a couple of ideas. Dental care, mentioned by Thomas as well, you see the bar, the share of this bar is the most important in comparison with the other quintiles. What about catastrophic? So this is so to speak, the overall picture. Now let's move to the specific catastrophic expenditure, which is the one that's over once you have paid for everything, housing, food and utilities, you are spending more than 40% of the rest on healthcare. This is catastrophic expenditure, okay? And may affect differently to the different quintiles of expenditure. As you said, 300,000 families in 2019, which is the last survey that was used in this study. It will be interesting to see how this moved in 2020, and whether the new policies on, for example, the minimum living income or the exemptions in co-payment change this picture in 2020 and 2021. So, but at the time, 2019, 1.6% of our households experimented catastrophic expenditure. So 300,000. And the point is that there was an increase from 2006, the series that we used to compare over time. So almost more than doubled the number of households in this period of time. Of course, in the middle, there is a huge economic and financial crisis. But interestingly, 2 in 3 actually were in the poorest quintile. So this is the one point. Those experimenting catastrophic expenditure were concentrated within the poorest quintile. Going a bit further on this, and this is very interesting. This is when I use the impoverishment thing in the argument. Look at in 2006, left-hand side. The green bar represents those without any risk of impoverishment. Were those in 2006 where we're experimenting catastrophic expenditure. However, see the red bar over the years, who are experimenting currently, or in 2019, who were experimenting catastrophic expenditure were the poorest. Okay, which represents that more or less 68% of those were experimenting this catastrophic expenditure. The reasons behind the catastrophic expenditure more in detail. So is dental care actually who is behind the 75% of the catastrophic expenditure? But you have to take into account that what I said, also the medical products. So when taking into account the dentists, any dental material, when you move this to the dental care, you get this 75%. Okay. And then the second reason is co-payment, drugs co-payment. 60% of the catastrophic expenditure goes that way. And in this case, obviously, the increase of this share has been dramatic because of the policies of co-payment in 2012. Now change. So the picture will be very different because of the 7 million people exempted of co-payment in the 2020 legislation. So that enter into obligation in 2021. So that this will be very, very different maybe. Across quintals of expenditure, this is a bit different. And you will see that, for example, on top of the image is the poorest quintile. You'll see that this distribution is actually on drugs, basically on drugs and medical products. And in the case of the better off, you will see that is about hospital assistance, which has increased the last year of the series. So in the end, the reason is dental care, is drugs co-payment. But if you look at across quintals, there is a difference. This dental care is co-payment, drugs co-payment in the poorest clearly, in the richest is hospital assistance. So you can see there, or move a bit towards the idea of whether we are covering or not properly using voluntary health insurance, supplementary, the care of the individuals, and who is actually buying those premiums. With regard to the second big indicator, unmet needs, oh, sorry. So you will see, and this is quite a very interesting, I mean, it's very constant over the years, and it's one of the values of our system when we, in terms of care, healthcare, the definition is not clear. It's always we're struggling always with the definitions and the consistency of the definitions and so on and so forth. But anyway, what healthcare means here is everything except dental care in the end. And you will see blue line is the average Europe and red line is Spain. Top of the image, you will see that is far below the average of the European Union. So the level of unmet needs for healthcare in Spain is very, very low. In the case of dental care, there is a difference. And actually we are coming from being below and now we are above the average of the European Union. Okay, but again, this is the average. What is behind the numbers? In healthcare, actually, the difference between the highest quintile and the lowest quintile is very, I mean, there is a difference. It's constant over the years, but it's almost nothing. In the case of dental care, this is the difference for the poorest in red and for the richest in green. So the difference is huge across quintals in dental care unmet needs, far from the average of you, and increasing over time. Obviously, there is a consequence, that is, if I cannot be cared by the system, I have to pay for a voluntary health insurance, and we are witnessing an increase in voluntary health insurance in Spain over the years. But who is buying those? Actually are the richest. Just 10% of those in the lowest quintile are buying voluntary health insurance to cover the unmet needs. A bit of discussion actually is Tamas already is the same image. Again, is this correlation that we see, even though for the same level of out-pocket, we can see countries as Romania, Italy, Poland, Estonia, even almost Finland and Austria are, you know, with higher levels of catastrophic expenditure on the y-axis. So what is the reason behind this, so to speak, well behavior Spain for this high level of out-pocket? Comes from the idea that I raised at the beginning. This is about who is covered, what is covered, and how is paid, and who is paying for it. And then the discussion comes to the actual institutional design of the Spanish health system. And also about the institutional design of the welfare state in Spain. It's not just about what we are doing within the system, it's also about what we are doing in the welfare state. And then to just set up a number of reasons, underlying reasons, again, it's not causation, is hypothesizing of what is behind this good behavior. Is actually what is the entitlement in policy in Spain, who has the right to be covered and is just being resident. We can say that there are some administrative barriers for some poor people, sure. Even refugees, sure. But in general speaking, virtually all the population that resides in Spain is covered entirely for the whole basket of benefits. The supply is actually distributed quite evenly across the system. So the idea of having a design that allows a primary care physician every 1,500 patients or residents, so to speak, is a good idea. But also the secondary care is distributed geographically quite evenly. So this is, in terms of effective access to good care, the population is close to that. The co-payment, even though it's actually a big share, is actually soft. And after 2020, it's a typo there. After 2020, we do have a different policy on co-payments, a lot of exemptions. There are very strong exceptions, so we have to take this into account, but the design of the co-payment is actually quite a soft one. There are caps, it's proportional to income, even though we can discuss about how much proportional is, because it's just 3 ranges in that, but it's still, this is proportional to income. Then there are caps, the caps, except for those that are working currently, are active workers. But there are caps for the pensioners, and also there are caps for some specific drugs, and for example, those in chronic conditions. So there are elements in the design that makes this co-payment system soft, so to speak. And then the public health expenditure is actually very redistributive because of the money is spent in primary care. We may want to say, well, we need more on primary care. Yes, it's okay. But we are putting so much money on primary care that is redistributing. Actually, the 15%, there is a study on the 2 deciles, that the poorest deciles in income, in this case, deciles, that shows that the population in those 2 deciles, the 20% of the poorest population, that gets an increase in kind of 15% of the household budget, just because of the primary care. So interesting. And then out of the healthcare system, there are 2 elements: the redistributive capacity of the expenditure, public expenditure on the education system, on the social security, and also is now coming in action. So we have to test whether there is an actual impact, but the minimum living salary is actually meant to cover, to move actually the basic needs up at some point. Obviously, some implications from our system, and this is my last slide. The idea could be then, even though, I mean, we are doing, in comparative terms rather well, we have to pay much more attention to those poorest households, increasing the coverage of dental care. We should not forget optical care. Never mentioned, because there are no statistics. And what about mental health? I forgot putting in here. Okay, mental health, poverty are quite closely correlated. We can improve the co-payment design. For example, putting some caps on those workers, active workers. I mean, there are workers, but they might be poor. So let's put a gap there as well. Is of course a need reducing the barriers for effective access to the services. For example, reducing waiting times, reducing the incentives for voluntary health insurance premiums, or reducing or revising this third statutory system that we have in Spain, that is the mutualities for civil servants. Then, of course, we can improve the effective access to care, reducing administrative barriers to those less affluent people. Actually, refugees are suffering from administrative barriers, just to put an example, undocumented migrants as well. And then take a look at how to cover those unmet needs in the end. And the unmet needs in Spain basically are concentrated on dental care. So thank you very much for having me today.
Thank you, Enrique. Well, you showed the slides, at least in Castellano, but thank you very much for speaking in English, although it was only for my benefit, not to the benefit of the majority. But I would suggest actually that if there are any questions, maybe it's best to have it now on the Spanish report, or else we can of course have a discussion at the end after Sarah's talk, because Sarah will have a slightly different topic to address, not really the core issues, and probably Enrique will have lots of questions to answer, and feel free to switch to Castellano so that we make sure that he answers and not me, because I will not understand. Yes, there is a question. We need to use the microphone, right?
Oh, hello. Thank you very much for your presentation. I actually knew the study. I read it some time ago already. And that's precisely part of how I want to start my question. We are producing these very interesting studies, very powerful data. And when are we going to move to policy? When are we trying to push for changes using precisely these data? And in that sense, I would not agree with Quique in his diagnosis that our copayment system is almost proportional and it's soft. I don't think it's soft for most people, for a lot of people. And I am a defender of the copayment system. I defend that there should be some copayment, but I think our design is not good. And I'm afraid that this study may kind of be too complacent with our policymakers, and they think that everything is all right and everything is good and we don't need to do much. So first of all, I think we have to point out that the data on the copayment of medicines, we really don't know it, because those statistics on the expenditures coming from the household budget survey, they include both medicines bought with a subsidy, and without a subsidy. So we don't know very well, and that was not like that before. In the 90s, our data was better in that sense, because it distinguished between medicines bought with a subsidy and medicines bought without a subsidy out of the country. And I think that so we shouldn't be, well, maybe the data is good and everybody just goes and buy eye drops, but even eye drops that are not covered, that are not financed publicly, I think that's a source of inequity, because eye drops are good for you, and why should not be they covered for some people? So I think those things, we have to stress those points. And again, we know now that the two first these quintiles, or I would say deciles, so the first quintile of income is no longer majorly composed by pensioners, who are the ones that have a cap in the copayment. Most of those people now are young, active workers with very low salaries. And for them to pay a 40 or 50% of the medicines may be quite unfair. And therefore, I'm just afraid that being, using the words soft or proportional, because it's not proportional, when you have an income bracket between 18,000 and 100,000 euros. I mean, there is a world of difference between how you live in Spain with 18,000 euros a year and 100,000 euros a year. It's not comparable at all. So I would be very, careful of using the words proportional and soft, because I don't think it's soft. I really want to push for a change in the design of the copayments. And that's why I think we should, the data are good and we have a lot, but we have to really push forward. So that's one of my comments. And the other comments, I'm glad you said it at the end, Kike, because, well, you remember when I reviewed the study about mental health, that's such a gap in our system. It's such a black hole in our system. Because yes, it is covered more or less, but it's so sparsely. When you are given an appointment of, once every 3 months, how good is that? I mean, we cannot be happy with our coverage in mental health. And I think that should be pointed when we talk about unmet needs, because people don't even use it because they don't go, they don't have access, you are not sent to it. So I would just stress those 2 points. It's a very good study. I like it. I think you've done a wonderful work, but I think we should interpret it in a more, how would I say, less complacent way. Okay, thank you.
Thank you, Marisol. I cannot more agree with you, but in terms of the methodology, is the methodology that we have. Maybe in terms of the qualification is where we can, or you can disagree more. But in the end, using the household budgets is what you have, and there are intrinsic limitations. And then, because in the end, and I stress this point, this is a comparative study. So soft in terms of what? Soft in terms of the, what we see in other countries. You've seen, for example, the reddish columns that showed. So in terms of that, so for internal interpretation, maybe the soft is not a good word. In terms of the international comparison, maybe. So both things are true. I do buy your point completely. If I were to think of internally and provide a message to the policymakers, I would say, come on, it's not proportional. It's 4, 5 brackets, and this actually the active workers should have a cap, because they are working but for nothing. So no, I cannot more agree with you. But maybe the nuance is that this being comparative, you have to use the same methodology. Being comparative, the judgments that you do actually are in comparison with, and then maybe the words are not precise enough in terms of the internal discussion. But it's okay. Thank you very much, by the way, for your support and the review.
Can I just also briefly add? I cannot. I'm fully with you, and I'm absolutely supportive of being very critical about your own system. And this is where I see that, maybe it's not the best to look at the comparison across the European region and even within EU, because you're doing so well compared to others that it leads to complacency. And there are major gaps, and gaps also in terms of what we have information about. And it's great that mental health came up, because that's a major issue, both in terms of not having data on it, also in terms of potentially huge unmet need, and those who actually do seek healthcare do so more through private than publicly covered services. So there are these gaps, and we have to address. So once data is there, it's good because it generates new research questions as well. But on co-payments, I do believe that Spain has room to improve for medicines, and also some of the medicines that are not covered. And for why? You know, I raised this in the context of percentage co-payments. That's also so unfair to those patients who are unlucky to have an expensive medicine, if that's a percentage co-payment. But it's the same for you know, eye drops. I need them because of after a surgery, I need them. And why is it that it's not covered at all? And it's not covered, by the way, in the WHO insurance either. So we are not better off at all. So thank you very much for these comments. And let me just say that I don't know if you spotted, but the best performing country on this end was Slovenia. And the most unhappy response we received was from Slovenia. They said, oh, it cannot be right. We think that things are not so rosy and not so nice. And that's where I feel that the country-specific analysis is what they have to look at. And then that offers actually room for improvement and very concrete policy suggestions where to improve further. And then maybe the comparative charts are less important, but they were really objecting the results, just as on the other end of the spectrum, like Albania and Bulgaria, they were very unhappy about it because it's so bad and they don't know where to start. And again, that's where I believe what we try to do with the national experts is to find those areas where to start. And I think you highlighted several of those. So thanks very much for this comment.
Before moving on, me gustaría también animar a las personas que están conectadas vía webinar para que pregunten, no importa, puede ser en castellano o catalán, aquí traduciremos al inglés. Anybody connected from outside, any questions? Y aquí en la sala, in the room.
Sí.
Oriol,
Si me preguntar, puedes So, thank you very much. I think it's a very important research. But I think this dental care issue deserves other ways of looking at it. I think I'm not an expert, and because suggesting tools of research is completely free, especially if you don't have responsibility on a resource allocation budget at all. But obviously, dental care went into a complete revolution in the last 10, 15 years. I mean, you know very well that these big chains that you can borrow money from to get treatment care, pay, you know, returns or pay in full. Most of these companies went bankrupt. Not most of them. Few of them went bankrupt. So when you talk to dentists, they talk about that model as well. So they are implying people have to change their teeth just in case something happens. There's no evidence that that's the right way of doing that. And the complete market in dental care now is the consumer market, which deserves, I think, some way of looking at as a financial enterprise, which is affecting people's expenditure. I'm saying that for dental care. I could say the same for aesthetic care. I mean, and we saw that change again dramatically with the big waves of migration to Latin America, where it's a well-established market there. So there's a lot of medical delivery care in the country, which obviously we are labeling because our medical under the healthcare expenditure. But you know, we don't label hairdressers as healthcare, and they're in that same basket. So I think, you know, going into those problems will probably give us a different light on what this dental care means. But that's the suggestion for the research.
We have two questions from outside. Tenemos dos preguntas desde el webinar. Veo la manita del Tony Peris. También lo ha escrito, pero puedes activar tu micro y hablar, Tony. Y luego Marco. Sí, ahora tienes micro.
Hola, ¿me oyes? ¿Sí?
Pero no te oímos.
¿No me oís?
No lo estamos oyendo. En la sala no.
¿Me oís?
No lo oímos aquí.
¿No me podéis oír?
Ahora puedes repetir,
¿Ahora?
por favor.
¿Ahora me oís?
Ahora sí.
Perfecto. Hola, buenos días. Hello, thanks a lot, Thomas, Enrique, for your presentation. It's very interesting. I have a question and a comment. On one hand, a bit, despite I agree that the payment may be improved, I am a bit surprised that it causes so much trouble because most of the chronic treatments and the most expensive ones are covered. It's true that ophthalmological treatments and some other treatments are not. That's for true, but I'm a bit confused. What specific drugs may cause this? On the other hand, I'd like to comment a possible confusion factor for the study. That's considering dependent people. I admit that it's a social issue. I mean, maybe it's not a directly health factor, but dependent people mean a whole problem for the whole family because of the amount of money that's to be spent related to welfare, but also because it's not the income of the dependent one who's paying for it, but it's the income of some other in the family. And maybe that may explain, for those families at risk of impovering, a dependent senior may cause a severe cause of being broken. I like to comment that with you.
Un momentito que voy a intentar, porque tenemos un problema de audio en la sala, voy a repetirle a mi ponente. The question was first regarding the co-payment. He was surprised because of the lots of exemptions that are like chronic condition and so on that have very important exemptions. So he said there is room for interpretation there. And another thing regarding the catastrophic payments, that if there is not something, if it has been considered that people who are dependent, that they may not depend on the salary of the person, but on the salary of somebody else in the family. Two other issues could have any impact on this explanation.
Excuse me that I couldn't listen to you properly, Tony. Well, you have to think that the exemptions as such, exemptions are coming from 2020 on, and these data are before that. So is the survey on 2019, the last year, and the big ones, the 7 million people exemption is just after 2020. And those co-payments, even though in chronic drugs, drugs for chronic conditions, there is a reduction, but not an exception. So there is still some co-payment in there. And then you have all the active workers. The active workers they don't have any capital, and then they have to co-pay according to the income they have. And most of them are above the 18,000 per year. So in the end, there is here, so there is a lot of people in there if you count on that. So I guess this is not contradictory, but I cannot respond, let's say, with specific numbers on who is who where. But in any case, the big exemptions, 7 million people, is not included in this study, and it's worth going into it in a new study. When it comes to the other one, was about the. Okay. Well, depends on whether it's a survey. There is a sampling method in there. So if they cover already this, we can have a accurate measure, representative measure of households that are also having a dependent individual in the house. take into account that you take the income for the one that is actually the first, the maintainer, so to speak, of the household, who is taken into account in these surveys. But anyway, there is a sampling methodology in there. So depending on whether the sampling methodology is covering well the different strata that you may think of important to get insight on a specific study, you will get this cover or not. I cannot respond to you. I can double check if in the microdata of the household survey, a budget survey, there is a representation of the types of individuals included in the households, and whether the sampling methodology, I doubt that the sampling methodology includes this in any case. Includes it? And is representative?
Había otra pregunta de Marco Cornejo. Marco. Tienes que activar
Ya.
el micro.
Buen día, ¿me escuchan?
A ver si ahora te oímos.
¿Me escuchan ahora? Hola, Marco Cornejo.
Todavía.
Hola, hola, hola. Hola.
Ahora sí, espera
Hola.
un momentito
Hola.
que te oímos, pero bajito.
Vale, voy a tratar de hablar más alto. Marco Cornejo de Chile, un gusto saludarles.
Un segundo. A ver ahora.
Hola, ¿me escuchan ahora?
No.
Hola.
Un momento, te oímos, pero bajito. Un momentito.
Hola.
Un segundo.
Sí, estoy probando.
A ver ahora.
Hola, hola. ¿Ahora, María Luisa?
Ahora, Marco.
Si me escuchas bien, a lo mejor puedes traducir tú por el tiempo de los demás, ¿no?
Sí, también tiene que cualquiera. Sí, sí, tranquilo, que tenemos también gente que entiende español en el panel. Dale.
Vale, bueno, primero que nada felicitar por esta interesante sesión, agradecerla, un tema que es contingente en todo el contexto global, yo creo. Y por supuesto yo soy odontólogo, me parece súper interesante el relevar la importancia que tiene el gasto en servicio odontológico, particularmente el alto porcentaje de gasto bolsillo, un tema que tiene marcado a España, ¿verdad?, en el contexto global, así que agradezco tremendamente la evidencia que nos presenta el profesor Bernal. Yo quería agregar y valorar como comentario los datos de la mirada económica, ¿no? Que son sin duda súper relevantes en términos de todas las implicancias que tienen las barreras económicas para el acceso a servicios de salud. Pero sin duda que esto viene a sumarse a la evidencia científica también que habla de la importancia que tiene reincorporar o incorporar los cuidados a la salud bucal en el marco de los cuidados integrales en general y particularmente algunas poblaciones como son las personas mayores, ¿no? Que, sobre todo para el modelo español que clásicamente ha estado vinculado más la escasa protección odontológica que hay a poblaciones infantiles. Y por otro lado, solamente con esto acabo, contextualizar que me parece súper interesante este estudio de cara a las aportaciones que se han hecho de la OMS en términos de las declaraciones, de incorporar, que los sistemas de salud incorporen efectivamente y aumenten la cobertura de los servicios odontológicos en sus distintos contextos. Y por otro lado también, las sugerencias que ha habido respecto a la incorporación de, nosotros como odontólogos lo valoramos tremendamente, la incorporación de productos odontológicos que se utilizan en la atención odontológica en algunos contextos asistenciales y en otros de salud pública, como parte del listado de medicamentos esenciales, ¿no? Entre ellos el vidrio ionómero, bueno, el fluoruro que sí se utiliza en España, y otros productos, ¿no? Cuatro productos, cuatro medicamentos que están incorporados desde una mirada ontológica a la lista de medicamentos esenciales, que yo creo que también es importante tenerlo en cuenta de cara a pensar en inversiones o aumento de inversiones. Muchísimas gracias a los expositores por su interesante exposición.
Gracias. There was a comment. Here's another one.
Highlighting the relevance of dental care and also the position of the WHO highlighting this in the integral documents, integral care, also including dental care.
And some drugs. essential drugs.
Muchas gracias, Marco. Entonces, ¿hay más preguntas en la sala? In the room or in the webinar? Online? No. No. Don't see anything. Then we can carry on.
Thank you. I was going to, yes, I think I was going to sit down, but then I think that you can't see me because the screen is right in front of me. So I think I'll just
Move a bit so you have enough space.
Is this on? Can you hear me? Can you hear me now? Is it okay? Yeah, okay, good. So we had a very deep dive into the situation in Spain with financial protection. Tamás gave a bit of an overview of the European context. We're going to take a step back now and look at what Maria Luisa asked us to look at, lessons from Europe for Spain in terms of health financing resilience. And I've given the title of my talk here as austerity is not an option, or is it? How does this work? Okay. No. Oh, okay, it's working great. So I'm going to look at this question, and I have three parts. First, I want to just give a little bit of an introduction to what we mean by resilience and health financing policy. And then I want to look at the two crises that we've experienced in Europe in the last 15 years. And I can hardly believe it that the start of the global financial crisis was now 15 years ago. It doesn't seem that it doesn't seem possible that it could be that long ago. But I want to just extract some lessons from health system responses to the global financial crisis in 2008, based on a study that WHO and the Observatory did together and published in 2015. And then I want to look at lessons from health policy responses to COVID-19. And again, based on work that we've done in WHO, we had a regional report in 2021 looking at patterns of health spending across the region, touching on the COVID issue. And then last year, a journal article where we looked at these two different crises together and asked whether we could draw lessons for Europe from those two experiences. So first of all, I think we all know what resilience in health systems means now that we've been through the last 15 years with the global financial crisis and then the pandemic. But it might not be quite so obvious what we mean when we talk about resilience in health financing policy. So this really has two factors. The first is that your health financing policy should be pretty robust. It needs to be quite good in terms of its starting point, and I'll explain what I mean by that in a minute. And the second factor is that it should be counter-cyclical. Now, this is a very fancy economic term, but what it really basically means in plain English is that the protection that your health system provides, the coverage policy, and the money that you have for the health system to finance health services should really ideally increase as need for health services increases. As the economy goes down, the need for healthcare is likely to increase, and the money that you have and the coverage that you provide should increase counter-cyclically. So a resilient coverage policy would be one in which there are no real major gaps in policy to start with, so that's the good side of it. The system provides extra protection for people who need more protection, people with chronic conditions, multiple chronic conditions, low-income households, for example. And that protection should be counter-cyclical. So as the economy contracts and as your need for healthcare increases, that should not be the point at which you lose your coverage. Okay, you should actually have better protection in those circumstances. And this is a really important thing, to link resilience to health system goals, because we can talk about resilience or financial sustainability, but what we mean is that a health system should be able to continue to meet its objectives even in the face of a shock. And if a health system is not protecting people financially in the face of an economic shock, then it's really not being resilient. Resilience in revenue, in providing money for the health system. Again, the starting point should be that the money for the health system needs to be predominantly public, and the out-of-pocket payment share should be very, very small. And I think Tamas and Enrique have done a very good job of showing us why that is. It also needs to be enough to meet the health needs of the population. And in response to a shock, it really needs to be counter-cyclical. So if your economy is experiencing a shock, unemployment is going up, people's need for healthcare is going up, you really don't want your revenue base to be shrinking at that point. And many countries in Europe rely really heavily on the labor market to finance their health system. So now lessons from the 2008 economic crisis. And I just want to summarize 4 high-level lessons. If you're interested in the details, you can look at our studies online. So the first one was that in response to the crisis in Europe, and remember that the crisis was very severe in some countries, it was possible to find money, extra public money for the health system, even in the midst of an economic crisis. But if the crisis was very severe, and especially if it was prolonged, as it was in many countries, particularly in Greece, then it was not enough. The second lesson was that the cuts that took place during the crisis really had a very long-lasting impact. And if we look back, we look at the numbers going from 2008 to 2012, and then after the crisis from 2013 to 2018, we can see that there was really a decade of slower growth in public spending on health in Europe. And in the chart here, you can see that the chart is divided into 3 periods: before the economic crisis, the years of the crisis, and the years after the crisis. Before the crisis, the column in green, which is public spending on health was growing faster than the economy and faster than out-of-pocket payments, importantly. Then the crisis hit, GDP was very restricted, constricted, contracted. Public spending on health wasn't negative growth, but it really slowed down massively, and out-of-pocket payments continue to grow at a slightly faster rate than public spending on health. And then coming out of the crisis, you see GDP bounces almost back to its pre-crisis levels. Public spending on health also increases, but not as much as GDP, not keeping in pace with the economy, and out-of-pocket payments increasing at a faster pace than public spending on health. So really quite a long-lasting legacy from the crisis, the original crisis. Many people expected that it would be possible, it was an opportunity for countries to make savings through being more efficient at a time of crisis. And what we saw across the range of countries, the 40 countries that we included in our study, was that this was not, it sounded like common sense, but it was not actually true in reality. It was very difficult to be efficient in a crisis situation. People made rushed implementation of new projects. There were cuts that were across the board, not thinking about the effect of those cuts. And we can really see the consequences of that the cuts, both in terms of spending, cuts in terms of staff, human resources, and cuts in terms of coverage restrictions, really had serious consequences for the health systems that were most badly affected. And I just remind you that when it comes to coverage policy, 6 countries reduced entitlement to publicly financed healthcare. 17 countries made really ad hoc reductions in the benefits package, not linking this to evidence of cost effectiveness, but simply cutting the benefits package. And 24 countries out of 40 increased user charges. There was really quite a large shifting of costs onto households during the period of the crisis in response to the crisis. And we can see here the clear impact of those decisions on key outcome indicators for the health system, key universal health coverage indicators. The first one is unmet need for healthcare, and the second chart shows you the incidence of catastrophic spending on health. And this is the group of countries that was particularly badly hit by the economic crisis. But you can see quite large increases in unmet need in Greece and Latvia, even in Ireland and the UK starting from a much lower base. And then again, increases in catastrophic health spending before and after the crisis, really quite significant jumps in Cyprus, in Greece, and in Latvia. These were probably the direct result of a combination of health system responses and the impact that the economic crisis had on households, these 2 factors together. So very clear evidence of this. We can't say anymore that we don't know what would happen. We don't know what would happen if we make these types of changes in health systems again. Moving on now to looking at the lessons from the COVID pandemic. we took the information, all the details of the methods are in the health policy article, but we used the Observatory, WHO and European Commission COVID Monitor, which was monitoring country responses to COVID in real time. I think, Enrique, you were also part of that project, to look at the kinds of changes, the policy responses that people made in terms of health financing policy across, again, around 45 countries. And in the paper, we say that you could look at what happened from two different perspectives. And the first perspective is a more optimistic one. This is the glass half full perspective. Governments across Europe really reacted very quickly to the pandemic and found money really quickly, public money to put into the pandemic. And if we look at the change in public spending on health per person in 2020 compared to 2019, we can see that across the EU countries, on average, public spending on health per person increased by about 10%. But there's a big variation across countries, ranging from about 2% in France, 4% in Germany, 7% in Spain, up to 50% in Cyprus, which was also implementing health system reforms at the same time. So governments found a lot of money for the health system quite quickly. Many governments, it seems, learned from the lessons of the 2008 crisis and did not, in reaction to that crisis, many countries cut coverage. In response to the pandemic, there were increases in coverage. So countries moved quickly to make sure that uninsured people like migrants, people who could not afford to pay social health contributions, those contributions in many countries were waived so that people would not lose coverage precisely at a time when they really needed it. Many countries also reduced user charges, obviously for COVID treatment, but sometimes for other types of treatment as well. And some countries like Cyprus and Ireland were able to push forward quite significant reforms in access to healthcare in the midst of the pandemic. And the other reason to be optimistic, and a clear difference from the previous crisis, was that the international financial institutions, the European Union for one and the IMF for the other, were very, very supportive of measures that governments took. They were really strong advocates for more public spending on health, more public spending on social protection, better tax systems so that tax systems were fairer and more effective. And they were also strong advocates for focusing on reducing inequalities, because this was something that became very visible as the pandemic went on. So the glass half full, it really seemed, at least by the end of 2021, that there was quite a strong post-austerity consensus that cuts in health spending, making cuts would be a very short-term thing to do and would not be the right thing to do. On the other hand, the other perspective, the more pessimistic perspective, would be that actually we saw that many countries were not well prepared to meet the shock of the pandemic, both the health shock and the economic shock that accompanied it in some cases. And this was mainly the case in countries with social health insurance systems. These countries had to take a lot of measures to ensure that people didn't lose coverage, as they might have lost work because of the lockdowns and so on, but also to make sure that their systems didn't lose money through the same issues of people losing work and so on. So it's disappointing, I think, to us to see that they had 5 years between the end of the global financial crisis, the economic crisis, and the pandemic. And in that time, measures were not put in place to change those systems. And countries again had to scramble to react to the crisis as it happened. And the other thing that we argued in the paper was that the financial pressure was really likely to grow. A lot of money was put into COVID in 2020 and 2021. But as time went on, this was likely to no longer be the case, and systems were going to feel financial pressure once again.